I assure you that what you will observe is a vast wasteland.
Free and uncorrupted communication.
I'd like to, this evening, to talk to you a little bit more about what Doctors Without Borders does, why we do it. I want to talk to you a little bit about the people we try to assist, and a lot also about the challenges we face as we carry out our medical humanitarian work around the world. And to do that, I've brought some video footage to help us focus on 4 crises that we're currently responding to. The Democratic Republic of Congo, that I'd like to start off with, Haiti, a war-torn country as well, but closer to home, Niger and the nutritional emergency that took place there last year in particular, and the HIV/AIDS pandemic. So I'll do that in conjunction with some video, because I think it's the images are very helpful to situate what's going on and to help start the conversation about what's happening in these areas. But before I move into these different crises, I just want to step back a little bit and talk a little bit about what humanitarian action is. Although Thomas did a great job in describing what we do and why we do it, I just wanted to say a few words about humanitarian action and our conception of our role and responsibilities. Humanitarian action is a word that's used a lot these days to describe a variety of things. When you boil it down to its fundamental, the really essential core of it, it's based on a very simple and straightforward conviction. The conviction that just ordinary people, whoever they are, wherever they may be, when they're caught up in conflict, when they're caught up in crisis, they deserve to be spared from the excesses of violence, and they deserve to receive some assistance to help them survive. It's a very simple and in many ways limited or even modest ambition. Is to really seek out those who are most in need, those who are in gravest danger, and to help them survive, to help as many as possible of them survive. When we do this, we of course aim to relieve people's suffering, and we help them restore their ability to make their own choices and rebuild their own futures. So it's really a focus on the most acute phase of the crisis when people are in greatest need and in greatest danger. And that's really the very simple and very powerful idea that's at the core of what MSF has been doing now for over 35 years. We were founded in 1971 by a group of doctors in France, and we are now an international organization. We have about 2,000 international staff working at any given time around the world in about 70 different countries, and they work hand in hand and alongside about 20,000 national staff, medical doctors, nurses, midwives, lab technicians, pharmacists, and other staff, non-medical staff, from the communities themselves, from the affected countries themselves. And our work is really a work that brings together international staff, people who've come in from abroad, and the national staff from the countries themselves. Our field teams really provide hands-on direct medical assistance. That's, they are in the hospitals, in the clinics, providing hands-on medical care to people in need, and focus on trying to make this assistance as effective as possible, to make sure that it really reaches people and they actually benefit from the assistance. In the process of delivering assistance, we're also committed to, as Thomas mentioned, to speaking out, to raising awareness about the conditions that people are in, the atrocities that our field teams witness, and also about the obstacles that we face when we deliver aid. The impact of speaking out is always uncertain. We don't know when we do speak out what the results will be, but we believe that silence and not saying anything is worse. And in that sense, speaking out is just an additional means that we have to try to improve the plight of the people we're trying to assist. Our teams in the field are backed by a network of national organizations around the world. There are 19 of them currently, including Doctors Without Borders here in the United States. And these organizations are active in backing the field teams, recruiting doctors, nurses, and other medical staff, non-medical staff as well, raising funds, private funds from individuals in particular to support the work in the field, and carrying out communications and advocacy work as well. We know, of course, that our actions in the field, given the scale and the magnitude of the problems that generate the need that we are responding to, we know that our actions in the field are necessarily limited and insufficient, but they are very concrete, they're very tangible, and they're addressed at helping people who are in real dire need. And when I illustrate the work that we do, what I hope will become clear tonight is the need for all of us to challenge really the complacency that allows these intolerable situations to persist. As I go through the different contexts and the different examples throughout this evening, I also want to draw your attention to two really vital points, two themes really that run throughout this presentation. The first one is the critical importance of independence. By definition, humanitarian aid has to be guided by need, by human need and by need alone. That's the principle of impartiality, non-discrimination, giving aid to anyone irrespective of their political, religious, economic and other characteristics, and proportionality, giving aid, more aid to those who need it the most, and prioritizing assistance. However, we all know that in practice, in real life, there are many, many obstacles to delivering aid based on need. Throughout our experience, we've become convinced that the best way to overcome these obstacles and to act impartially is to be independent as an organization from any political, economic, and religious agendas, and to have as well the independent means to act. The second point that I want to stress throughout this talk is the importance of innovation. The medical care that we provide in the field must be adapted, of course, to the conditions that our patients live in. But that does not mean that we should accept substandard or ineffective solutions. Really, on the contrary. To deliver effective quality care, we need adapted approaches, adapted to the field conditions. And to carry out these adapted approaches, we need appropriate medical tools, appropriate diagnostic tests, medicines, and vaccines. And for both the approach itself and the medical tools that allow this approach, we need innovation. Innovation is absolutely critical and absolutely vital. And tonight I want to give you an example of both of successful innovation, which is a new way we have to treat severe malnutrition. And I also want to highlight the huge problems that are caused by the lack of innovation in AIDS treatment for children in particular. But first, I'd like to take you to a country where we've worked for many years that has been characterized by many observers as one of the worst humanitarian disasters in the world. And our experience there certainly substantiates that claim. It's the Democratic Republic of Congo, or DRC. A very large country, the size of Western Europe, or twice the size of Texas, situated in the center of Africa. The Congo has had a very brutal colonial past, and then that was followed by decades of post-independence misrule. And in the past decade, the Congo has now been destroyed by 2 bouts of civil war. These are internal conflict involving Congolese players, government and rebel groups, a variety of rebel groups, but there's been extensive international involvement as well, and neighboring countries have fueled the war through their direct and indirect involvement. For many years now, there's been an internationally backed political process that tries to bring the Congo out of war and back on the road to peace. But despite the existence of this process, for many people in the Congo throughout different areas of the country, the conditions continue to be very grim indeed. And to illustrate this, I'd like to show you a video that was shot last year in Katanga province, which is a vital area of the Congo, very rich in natural resources, in diamond, gold, and other natural resources, but where, as you will see, the people who lived there were forced to live a very intolerably violent situation. So we'll be showing video on the screen back here.
On the way to the displaced camp of Mitwaba, Katanga province, southeast of the Democratic Republic of Congo. 9 difficult hours to get to the thousands of displaced persons to whom MSF has been providing aid for almost 10 months. Despite peace agreements signed in 2003, the army is still fighting with local militiamen. To escape the violence, thousands of women, men and children have fled their villages and are living in fear, hidden in the forest for weeks, sometimes months. Kialwe, the first in a long series of villages to be burnt. Thousands of victims left their homes and their land. On the 21st of July, new clashes forced the villagers to run again, for the second time in less than 6 months.
This is the nurse of Kialwe. He's telling us about these 2 women. She is a victim. Her husband was arrested behind this house, which was burned. Her husband was arrested and killed in the house. They cut off his arms, and then, what did they do with him?
No, they took his body to Mantoto.
Mitwaba was once the food basket of the region, an area covered in thousands of heads of cattle, now all gone. The fields are deserted. Extortion by armed groups is common. They take by force whatever harvest there is. Malnutrition affects adults as much as it affects children. This young woman has come to Mitwaba looking for safety. She is severely malnourished and has tuberculosis. Her sister was kidnapped.
She doesn't know where she is.
MSF provides nutritional and medical care to some 13,000 displaced people in the camps. In this region of the DRC, the closest hospital is 120 kilometers away. Half the patients who come here for consultations are local residents who have not had any access to healthcare for years. The mortality rates exceed emergency thresholds. Hunger, flight, sickness, these civilian populations bear a heavy burden, sometimes exacerbated by sexual violence that is still widely practiced by armed men. This girl is one of the victims, raped while on her way to the health center.
In April, I had to go to the health center in the city with my 3 sisters. On the way, we met an armed soldier. He caught me and forced me into the bush, and there he raped me. My sisters went to tell the army chief. The man was called in for questioning by his superiors, but was let off lightly. He paid me $1, and then he was freed. I'm afraid of being raped again.
One of the reasons I chose to highlight the Congo this evening is because it's very much a neglected or underreported emergency. For 8 years now, we've been issuing a list of the top 10 most underreported humanitarian stories here in the United States. We try to look at the severity and the magnitude of the problem that our field teams are dealing with on the one hand, and then the extent of media coverage on the other, to determine which countries, which contexts make this list. And in 2005, the Congo made that list yet again. It received a grand total of 6 minutes of coverage on the nightly news in the United States last year. I also chose the Congo because it's a conflict situation, and it's really a reaction to the excesses of war that prompted the birth of humanitarian action in the first place. In the late 19th century, it was the horror of the battlefield at Solferino, where he witnessed soldiers dying for lack of medical care, wounded soldiers who were lying on the battlefield and just dying there, that gave Henri Dunant the idea to create the Red Cross. And his very fundamental insight at that time was that wars exist, but within war there should be a space for humanity, for people who are out of combat, who are not participating in hostilities, prisoners of war, wounded soldiers, civilian populations. These people who are out of the active participation in the fighting deserve to be spared from the violence, and they deserve to receive assistance. And restraining the way that governments and armed groups wage war and respecting the work of humanitarian organizations, it's precisely what states around the world have signed up to when they endorsed the Geneva Conventions in the aftermath of World War II. It's really not by chance that MSF deploys more than half of its assistance in conflict areas, and for reasons that are quite apparent in this footage, Congo is among the highest. Today, in the Congo, attacking civilians has become a major aim for many of the belligerents. And this is something that we've seen also in other conflicts around the world. Sudan stands out in that regard as well. In addition to the direct and indirect impact on the civilian population, conflicts also destroy a country's infrastructure. Health services collapse, or they're otherwise unable to function. So here we have really a conjunction of high needs on the one hand, and then we have a low local capacity to respond. Then that really justifies and legitimizes the involvement of outsiders coming in to provide assistance, like MSF does in wartime. And it's really in those circumstances where you have this huge gap that our work can have very much a significant added value and save many lives. Since the footage you just saw was shot last year, the situation in Katanga has continued to worsen. More than 100,000 people have been freshly displaced in the past months and have been forced to live in temporary shelters. Behind the fighting is a bid by the government army to rein in and to control militia groups that they had supported and armed in the past when together they were fighting the armies from neighboring countries who had come into Katanga, in particular the Rwandese army. Now these former allies are fighting it out among themselves, and the population is caught in the middle. There's been recently an outbreak of cholera in this area, and as you know, cholera is a disease that has to be treated very quickly, and otherwise it becomes rapidly fatal. As well as providing medical care on the ground, we also do our best to try to raise awareness about what's going on in these forgotten crises like Katanga and Congo. And in January, just a few months ago, we alerted the UN Security Council in New York as to what was happening in Katanga and to the catastrophic situation there. This past summer, we also sent a group of world-renowned war photographers to the Congo to document what was happening. We're trying new ways to try to attract attention to what's happening there. And the result is a photographic exhibit that's been traveling internationally in the Congo itself as well, which is quite interesting, in Kinshasa and Kisangani and in neighboring countries. It's such a huge country that even within the Congo, people don't necessarily know what's happening in another part of the nation. This exhibit has opened in New York late last year and is opening actually tonight in Los Angeles at the Stephen Cohen Gallery. I'd like to take you now to another war-torn country, but this time closer to the United States. Haiti is only a few hundred miles from the US, and as you know, it's the poorest country in the Western Hemisphere, with very poor health indicators in particular. And here the media has been more active, and there's been coverage about the situation in Haiti in the past months, but mainly about the electoral process and the politics, and not really very much about what the population in Haiti, in particular the population of the capital city, Port-au-Prince, has been going through in the past a couple of years. In early 2004, then President Aristide was deposed by a combination. There was an armed insurgency, and then there was some diplomatic pressures, including from the US, and Aristide left the country. An interim government was set up, and it was supported by UN forces and the international community at large. Since that time, there was an ongoing, constant, kind of low-grade urban conflict in the capital city, Port-au-Prince. And throughout 2005 in particular, this violence centered very much on the slum areas and shanty towns in Port-au-Prince. And this violence involved quite a confusing array of belligerents. So you had, on the one hand, you had the interim government with its national police and the UN forces, and in a bid to kind of take out leaders of the armed groups that are still affiliated with former President Aristide, they worked together and carried out military operations in these shanty towns, in the slum areas. And on the other hand, you have a variety of armed factions with differing political, also criminal motivations, who are based, some of them based in these shanty towns, and are in conflict with the UN and the police on the one hand, and with each other on the other. So it sounds very confusing, but the result was very straightforward and simple in many ways. The civilian population was caught in the crossfire, in the middle, and many lives have been torn apart. What I'd like to show you now is some footage that was taken in our trauma center, surgical facility that we set up in Port-au-Prince to illustrate what has been happening there. And before I do, I have to warn you that some of the images, some of the pictures are quite graphic.
This man was shot in both thighs and in the foot. Every day, between 3 and 20 people with gunshot wounds are rushed to St. Joseph's Hospital. MSF opened a trauma center at St. Joseph's last December, and since then have treated 2,117 patients, 542 for gunshot wounds. Other injuries are related to car accidents, sexual and domestic violence, street violence, and burns.
No, it's a car crash.
Were they in the same car?
No.
They were in two different cars?
Yes.
And they ran into each other?
Yes.
Many need substantial surgical intervention.
This is a young man who was hit by 3 high-velocity bullets, like a Kalashnikov or M14. First, we have to make an initial assessment. Once his condition is stabilized, we will assess the functionality of his lower limbs, the mobility of his 2 thighs. After all, he's lost his tendons on both sides. Most of the patients who come in can't afford this kind of care. In a private hospital, it would cost between $20,000 and $30,000 American dollars.
In addition to the 56 beds in the hospital, Médecins Sans Frontières has opened a physical rehabilitation center, which can accommodate 20 inpatients, and offers follow-up care to many others on an outpatient basis. The cases treated here and the stories told by the patients attest to a situation of widespread violence, with 50% of the victims women and children.
People rob and destroy houses and rape women and girls. This is what's going on. Although it's mostly happening in the slums.
Since this facility opened in December 2004, we've treated nearly 8,000 people here at St. Joseph's Hospital, including more than 1,700 gunshot victims and 500 knifing victims. And as was explained in the footage, 50% are women and children. These are shockingly high numbers for a city like Port-au-Prince. And before MSF came, most people really had nowhere to go for emergency medical and surgical care. Especially people from the slum areas, poor people. They couldn't afford, for financial reasons, to go to the Haitian national hospitals. Or else they were also just too afraid. They feared that just by living in the slum or shantytown area, they would be perceived as being affiliated with one of the armed groups that operate there. And it's true that the police have had no qualms about entering hospitals to look for suspects. We had incidents in our own clinic, especially just after it opened, when the Haitian National Police entered looking for suspects to arrest. They wanted to arrest some of our patients. Our teams had to go to great lengths to explain why they could not allow this to happen, why the patients had to be treated first, and eventually succeeded in protecting the medical humanitarian space of the trauma center itself. But as you can imagine, establishing and running medical services like these in such violent, sensitive, and volatile environments is really not easy. You have to talk to everyone. You have to talk to the soldiers, to the police, the leaders of the armed groups. There are many of them operating in the slum areas. You have to talk to the UN forces, to the local population as well, to explain, who we are, why we're doing this, the provision of medical care, no questions asked to all who need it, so that people know that they can bring wounded patients to us without risk of arrest. For there to be no emergency or surgical services for a lot of the people being shot, raped, knifed in a city like Port-au-Prince, for us was clearly unacceptable, and we had to do something about it. Today, the situation in Port-au-Prince is relatively calm. We've seen a drop-off in the number of cases admitted to our trauma center. This drop-off started happening just in the run-up to the recent elections, and it's holding so far. We still have many, many people in rehabilitation, and as you saw, it's really not easy from a physical and psychological point of view to recover from the trauma of having been shot and maimed. And so we have still many people in that process. Now that there's been a new election and a president has been elected, we'll see if the relative calm that's prevailing will last, and of course we'll hope that it does. I've talked so far about two war-torn countries where you have civilians with huge needs that are caught in the middle of fighting forces, and where we know that our assistance can never be enough, but where we do focus on providing quality, effective care to the people that we can reach and we can help. I'd like to take you back to Africa now, but this time not to a war situation, but to Niger. Niger is a peaceful, democratic country located in West Africa, just south of the Sahara, north of Nigeria. It's very, very poor, and it bears actually the terrible distinction of having been classified as the least developed country in the world according to the UNDP's Human Development Index last year. So, year in, year out, many, many people in Niger live on the brink, whether they are pastoralists, relying on livestock, agro-pastoralists, combining livestock and some farming, or mainly farmers. Many people live on the brink year after year, and health indicators are very poor. In particular, infant mortality is very high. Last year, however, the situation in Niger was even worse than usual, and there was a major nutritional emergency that took place there, with hundreds of thousands of children under 5 suffering from acute severe malnutrition. Now, acute severe malnutrition is a very serious medical condition. It's characterized by a sudden drop in food intake among children, especially children under 5, that leads to a very rapid drop in their body weight. And we characterize the cutoff point, the threshold for severe acute malnutrition, when the body weight drops to less than 70% of what it should be for a given height. So these are very emaciated children, and they are very much at risk of death, especially contracting associated illnesses. It's estimated that between 30 and 50% of these children would die within weeks if they don't receive specialized nutritional rehabilitation that is appropriate to their condition and their metabolism at the time. In the United States, it's clear that kids in this condition would be rushed to an intensive care unit. So here, we had hundreds of thousands of children in this situation. And in many ways, it was an atypical situation, somewhat surprising, even somewhat shocking, because, as I mentioned earlier, that Niger is a peaceful, democratic country. And starvation, as we had known it, is usually linked to war. It's for the reasons that you saw in the video about the Congo. It's in war situations that you have people who are displaced from their homes, their crops are burnt, their livelihoods are affected, and that is conducive to malnutrition and to starvation. Amartya Sen, the Nobel Prize winning economist, even went as far as to say that famine cannot happen in a functioning democracy because people will not allow it to happen. Strictly speaking, what happened in Niger was not a famine in the sense that it did not affect all age classes. It really focused on the children under 5 and did not affect the adults and the elderly. But it was very much a very major nutritional emergency. The video I'm about to show you was filmed in April 2005, at the beginning of this emergency, when our teams working in southern Niger began to see really a sudden increase in the number of malnourished kids admitted to their feeding center in this, at the time. And they, as will be clear in the video, they knew that a major emergency was about to happen, in particular because the harvest at that time was many, many months away. And so you really have the hunger gap where people have no new food to harvest until 6 months from then in October. So this is the video that was shot in April of last year.
Children from villages in the Maradi and Tahua districts are suffering from severe malnutrition. Grain reserves were already low, and the moderate pricing system has not worked. The next harvest is not until October. In the meantime, the people need grain. Between January and April 2005, Médecins Sans Frontières treated over 3,000 severely malnourished children around Maradi. This is 2 to 3 times the average for the same period in previous years. To respond to these needs, MSF has enlarged its patient capacity. 2 new therapeutic feeding centers have been opened, and 500 hospital beds will soon be available. The number of ambulatory therapeutic feeding centers will be adjusted according to need. By monitoring patients on a weekly basis, this outpatient system reduces the number of hospitalizations and increases the number of patients MSF can treat. At the end of April, 800 of the 1,000 children in feeding programs were in the 7 ambulatory therapeutic feeding centers around Maradi. 820 tons of food, consisting of wheat, millet, beans, and vegetable oil, will be distributed to families of children admitted to the program for the severely malnourished. Médecins Sans Frontières calls upon all other humanitarian aid organizations to mobilize efforts and prevent the situation from deteriorating.
What happened in the months following this footage is in many ways a story of failure on the part of the international aid system to respond effectively to this impending disaster and allowing the emergency to actually happen. First of all, there was really a problem with the diagnosis of what was going on. Attention focused a lot on natural causes. There was a crop deficit of about 11% compared to the previous years. There was an ongoing drought. There were locusts. But that was actually missing the point. The fundamental reason that was explaining why malnutrition among children was rising was the skyrocketing price of food. As reserves were running out, the poorest people simply couldn't afford to buy food to feed their children. The usual response when you have rising malnutrition rates is to treat those affected, who are already the children who are already malnourished, and to distribute food free of charge to their families, so as to prevent further deterioration, to prevent more children from becoming malnourished. But this didn't happen in Niger. For many months, the government and its international development partners, since it's a very poor country, it works alongside major donors. So you have the French government, the European Union, the US government, UN agencies, simply refused to distribute food free of charge to the poorest families and the most vulnerable people in Niger. The reason was long-term development concerns. In the name of long-term development, they did not want to risk to create dependency among the population in Niger by giving out food and having handouts, so the avoidance of dependency on handouts. And in the name of long-term development, they did not want to destabilize the functioning of the free market by bringing in free food supplies and modifying supply and demand. So the only food available to the hundreds of thousands of starving children was available at a price, but it was a price that many families simply could not afford. At the same time, aid agencies were very slow to react to what was going on. Many, of course, had been preoccupied with the tsunami. We had hundreds of organizations deployed, hundreds of millions, if not billions of dollars. But this was April, May, 4 or 5 months after the emergency phase of this devastating crisis. These agencies were not flocking to Niger. You had hundreds of thousands of kids on the brink of death, no security problems, few logistical difficulties standing in the way of an emergency operation. But Niger remained off of almost everyone's radar. It really wasn't until July, the end of July 2005, when the BBC broadcast shocking images of starving kids, that the world finally took notice. These are the kinds of images we actually don't want to see. The images that of a crisis so far advanced, the peak of the crisis actually passed, and it becomes very difficult to actually prevent things from deteriorating further. These images did have an effect, though. They had the effect of kind of a snowball chain reaction. The ban on free food distribution was lifted. Contributions from donors suddenly increased. Other media groups started paying attention. Food was shipped, and there was an emergency operation that took place. But for many in Niger, it was too little and too late. So Niger is a story of failure, but I think within it there's also a very important story of success and a story of hope for the future. It was in Niger that MSF first used a new product to treat severe malnutrition, a new therapeutic food called plumpy-nut on a large scale. And with this new food, and I've brought actually a sample this evening for you to see what it looks like, this shiny wrapper here. Thanks to this product, we were able to treat over 63,000 severely malnourished children in Niger last year. Now, the revolutionary aspect of this is not the food itself, not this packet itself. I mean, this is actually not rocket science at all. This is peanut butter paste with vitamins and minerals. It's specially formulated to be adapted to the metabolism of a severely malnourished child, because you can't just give them any food. You can actually kill a severely malnourished child just by giving them food that is not adapted to their condition. This is specially formulated, but what it has allowed us to do is to treat malnutrition in a completely new way, from a programmatic point of view. In particular, it's allowed us to treat malnourished children at home. In the past, our traditional approach has always been to treat malnutrition in a hospital setting. So we set up, either we modified a hospital or we set up therapeutic feeding centers, which are essentially huge hospitals for the treatment of severe malnutrition. But as you can imagine, setting up these hospitals in a country like Niger or in the Congo or in Darfur for such huge numbers of kids is something that's very difficult. It's resource intensive, it's staff intensive. You have to, in particular, it relies on high energy milk. A severely malnourished child will get 5 feedings of milk a day. So you imagine the kitchens that have to be set up to be able to prepare this milk and to distribute it and so on. So it's a very difficult operation. And then in addition, because we have all these kids in the same place, you also have the problem of the diseases being passed from one to the other and having to treat those. So it's the innovative part about the use of plumpy-nut was now we can screen kids on an outpatient basis. We can screen them in a health center, in a clinic, and if they only have severe malnutrition and don't have any associated illness, we can send them home. We send them home with 2 packs of plumpy-nut a day. We give them a week's supply, and we monitor them in a week. and they can stay at home with their siblings. They don't disrupt the work of the family. The mother can actually continue to work and care for the other kids. That doesn't have to be with the child in the feeding center. So it's much more adapted. There's actually not much risk of the malnourished child not eating the food because they love it. It's so good. They just hang on to it, and it has a shiny wrapper, so the mother can see immediately if another kid has swiped it from the malnourished one. And it's been effective. I mean, our success rate with this approach has been curing 9 out of 10 severely malnourished kids. So it's 9 out of 10, 90% success rate. So it's really quite amazing. Thank you. And it's really only the 30% of children who have malnutrition and an associated medical condition that have to go and be treated in a hospital. So it's simpler, wider coverage, much more effective. What are the prospects for Niger this year? Well, last October's harvest was actually very good, which is a good sign. The problem is many people are so poor and they're already in debt, and they already sold their harvest before they actually harvested it. So cash and food reserves are actually running low yet again for many people in Niger. So we expect a high number of children to become severely malnourished again this year, unfortunately. However, malnutrition is starting to be recognized finally as a medical condition to be treated. It was not the case in Niger before. In most African countries, there's no monitoring of malnutrition on a routine basis. You can't go into a health center with a malnourished child and get treatment, such as this treatment. So it's starting to be recognized, although there's still, it's not yet implemented in the field, not yet translated into practice. Poor people are still charged for medical care, and you still don't have plum peanut in health centers in Niger. But there is a beginning of an awareness, and more agencies are involved, more organizations are involved, and hopefully more preventative measures are in place to prevent the kind of emergency the kind of emergency that we witnessed last year from happening this year again. Finally, I'd like to turn to HIV/AIDS. I think we're all familiar with the terrible statistics about the pandemic. Last year around the world there were 40 million people living with HIV, which is more than the population of the entire state of California. Last year there were 5 million people who were newly infected, 6 million people who were in urgent need of treatment with AIDS, and more than 3 million people died of AIDS. Working in Africa, but also in Latin America and in Asia in the late 1990s, our medical teams began to see in their clinics many patients dying of AIDS. But they also knew that the treatments that were saving and extending lives of patients in wealthy countries, in the United States and in Europe, had been developed and were being used and were effective, but they were simply not available for poor patients in poor countries. From a humanical point of view, from a humanitarian point of view, this was really unacceptable to us, and so we had to get involved. We now have about 60,000 patients on antiretroviral therapy in 29 countries in Africa, Latin America, and Asia, both in urban settings and rural settings. And the results are, as you'd expect, positive. We, of course, still have patients who die, in particular because many of them come at a very advanced stage of the disease and die within a few months, especially of associated illnesses such as tuberculosis, which is probably the #1 killer. But for the majority of our patients, no matter how poor, treatment is working. People take their drugs regularly, they gain weight, their immune systems recover, and they can move on to live full and productive lives. They often join groups of other people living with HIV/AIDS who are advocating for better treatment, who are supporting each other, and who are combating stigma, which is still a major problem in many parts of the world. In our experience, the availability of treatment has also enhanced prevention efforts. It has increased testing, people coming forward to know what their status is. This is so because when treatment is available, AIDS is no longer an automatic death sentence. We certainly don't have a model about how to treat AIDS in these settings. There are huge challenges, but we're learning along the way, and are very keen to share experience with other practitioners to improve the way we can try to tackle this pandemic. One of the things that we have learned is the importance of competition in the field of medicine and drugs to treat AIDS. In particular, the importance of having generic manufacturers join in and create more of a marketplace and competition among different sources and suppliers. Thanks to generic medicines, AIDS treatments are now affordable. At least the first-line standard therapies are now affordable for poor countries. So we had the cost of the standard first-line triple combination therapy dropped from $15,000 per patient per year, which it was in 2001, to now less than $200 per patient per year. So that has allowed treatment to actually take place. We still have many problems, however, beyond first-line therapy. And when patients need to switch to more powerful regimens, and this is happening increasingly because now we have patients who are, have 3-4 years of treatment, and when you're on treatment for so long, naturally, in some patients, resistance to the first-line therapy increases. So they need to switch to a more powerful second-line therapy, and there we run into the same kinds of problems that we had at the beginning with first-line treatments. These are the drugs that are available and very effective are manufactured by one company, a patent-holding manufacturer, the key drugs. So you have issues of both availability, registration status in developing countries. The drug has to be registered to be able to be used widely, and problems of price. I'm highlighting this because just yesterday we challenged one of the main manufacturers who was manufacturing one of the key drugs, second-line drugs called lopinavir ritonavir. Abbott Laboratories, they manufacture this drug under the brand name Kaletra. And they just come out with a great new version of this drug, which is heat stable, which means that it does not require refrigeration. So it's fantastic, and it seems to have been made for Africa. Because you don't have fridges, you have poor infrastructure. This drug is really well indicated for those conditions. However, it's only available here in the United States. It's only registered here and available here. And its price is, the average wholesale price is between $9,000 and $10,000 per patient per year. So huge problems of getting that drug for patients who need it. And we just placed an order with Abbott yesterday along with an open letter to their CEO and accompanying sign-on letter with many AIDS experts and activists and organizations who are really interested in using this drug, so that we can get this drug at a reduced price for patients who need it today. $500 is the price that Abbott is charging for the older version of Kaletra in developing countries, and we hope to get it at that price. We'll see how Abbott will respond to this challenge. Thank you. So the good news about AIDS is, as I mentioned, is that as treatment is progressing, we are learning, we are getting more experience and sharing the experience. Many more players have now become involved in AIDS treatment, organizations, governments even, including the US government, who has put up quite a lot of money for AIDS treatment. But the shocking news and the negative news is that only 1 million patients out of the 6 who require treatment today are in fact receiving antiretroviral therapy. And so the challenge really is very, very big to scale up and to increase the number of patients under treatment. I've talked about AIDS in general so far, but I'd like to focus for the last segment, the last video, on just one specific group of patients within the broader patient population, and that's children living with HIV and AIDS. And as you'll see in this video, there's a very, very acute problem of finding appropriate diagnostic tests that will allow us to detect AIDS in children and getting appropriate drugs so we can treat children living with HIV/AIDS. It's not a small problem. The need is huge. There are 2.2 million children with AIDS in the developing world in particular, and 500,000 children died of AIDS last year. So I'd like you to see this video that was shot in Kenya, East Africa, recently.
My son was called Jack. I gave birth to him in July 7th, and he was fine during birth. But at some point he started crying, and when I took him to the doctor, he had a problem with his chest. But I didn't suspect anything serious. And after 2 months, that is September 7th, he died at exactly 2 months.
Jack was HIV positive. He now rests in this children's cemetery in Nairobi, Kenya's capital city. Most of these children died of AIDS. These young victims only lived a few months, or a few years at best, a life that many have started not far from here, in Kibera. More than 1 million people in houses made of corrugated iron and mud. Kibera is the largest slum in Eastern Africa. As in many developing countries, AIDS takes a heavy toll on communities. Children are no exception to this. 120,000 Kenyan children currently live with HIV/AIDS. About 18,000 of them are in urgent need of antiretroviral treatment that would extend and improve the quality of their lives. The fact that so many children die of AIDS is due to the lack of adapted treatments and also to the impossibility of testing children early enough. This child, whose mother is HIV positive, is now old enough to be tested. Before the age of 1.5, it would have been useless. The routine test used is based on detecting antibodies to the virus. But all babies born to women with HIV carry their mother's antibodies until the age of 18 months. It is therefore impossible to tell whether the antibodies detected are the child's or the mother's. There is currently no simple and affordable diagnostic tool to detect HIV in young children. After a 15-minute wait, this woman learns the result of the test. Her daughter is HIV positive.
She has felt so shocked to learn the kid is positive, and it's very unfortunate, she says. It's very unfortunate for her kid. And she's asking me what is going to happen now.
This child is lucky enough to be put under treatment. Unfortunately, around half of all children with HIV/AIDS will never live to see their second birthday. From now on, the child will be monitored in this Médecins Sans Frontières clinic. It was set up in 1997 in the heart of Kibera in collaboration with the Kenyan Ministry of Health. There are very few children with AIDS in rich countries, thanks to effective measures to prevent mother-to-child transmission. But in developing countries, it is difficult to apply the same elementary standards in order to prevent babies from becoming infected. As a result, 95% of HIV-positive children are infected during pregnancy, at birth, or during breastfeeding. The lack of adapted treatments for infected children is another real challenge for medical staff. This pharmacist, for example, is explaining to a mother how to transform a drug for adults into a drug for her child. If properly dosed, the treatment is as efficient as the one offered to adults, but having to tinker with adult formulations adds an extra burden on caregivers and medical staff.
After folding the drugs, then she uses a bottle. Then she'll have to crush it to make sure it is in a powder form.
Breaking up tablets or crushing them into powder is hazardous. A slight overdose can be toxic for these young patients, whereas underdosing can lead to development of resistance, which will make treatment inefficient. Of the 2.5 million children with HIV/AIDS worldwide, 9 out of 10 are African. Only a few thousand of them have access to treatment. Brenda, for instance, grew up without her parents, who died of AIDS. She's 10 years old, an unusually high age among HIV-positive children. She knows exactly how precious access to treatment is.
They started giving me that medicine, and then now my body is strong.
Branda also understands that she needs to take her medicines regularly.
I take this medicine the time which the doctor have told me. If I won't take that time, I won't.
Without treatment, half of all children with HIV/AIDS will die before their second birthday. We desperately need diagnostic tests that work for babies and pills that kids can swallow.
Last year there were less than 60 children born with HIV in the United States. And that's, of course, very positive news. But it's news that has perverse consequences. The perverse consequence is that there's really no incentive for the research and development of treatments for children, poor children living in poor countries. I don't think we can accept that children should be denied treatment because they're too young or too poor to advocate for themselves. And we will all need to get more involved and more active if the children that you just saw in this film and the many others just like them are to receive the treatments they need. MSF teams are at work around the world. We have teams in Colombia dealing with the consequences of the civil war there, treating, for instance, treating TB in Central Asia, responding to the aftermath of the earthquake in Pakistan. This evening I only talked about 4 contexts, the Congo, Haiti, Niger, and the AIDS pandemic. And in doing so I tried to bring attention to 2 critical points. The first one is that it's really crucial for us to maintain our independence if we are to remain as effective humanitarian players as possible. In order to improve our chances of reaching victims on all sides, of assisting those who require the most help, of minimizing as far as possible the security risks to our medical teams, we have to be independent from all political, religious, or economic forces. And something that's a far greater challenge than that, we have to be perceived as such. This is why we won't join in the so-called integrated approach that has characterized the international response to crises in recent years, including those in Afghanistan and Iraq. These responses are often led by Western governments, with or without the United Nations, and they have very broad and ambitious goals to bring peace, to restore security, to rebuild societies. And they act through different means: military intervention, political action, and as well provision of assistance, most often to win over the hearts and minds of the affected population. There's very significant pressure on humanitarian organizations to join in these efforts, to be in many ways the assistance piece of this kind of broader strategy at play. I referred to Haiti earlier, where the UN became an actor in the conflict in the name of restoring law and order in that country. What I hope I made clear is that if we want to be able to provide assistance to all of those who are affected by this process, we can't be a part of it. Even from the narrow point of view of providing assistance, the international response is very often ineffective and inappropriate. Too often the response is based on media attention, whether it exists or not, or political interests, again, whether they exist or not. And this leads to disproportionate assistance, either an overreaction or underreaction, not assistance based and proportionate to needs. In order to respond to needs and to be based on those needs, we need to have the means to do so. And at MSF we recognized long ago that financial independence was really key and crucial for our operational independence. If we want to be flexible, if we want to go where the needs are the greatest, we can't afford to wait for government donors, and we can't afford to follow their priorities. So we made a very strategic decision to build up a base of support, a base of people who could back and support our actions, a constituency in many ways. And on the international level now, 80% of our funding comes from private sources, private donors, essentially individuals. Here in the United States, it's 100%. 100% of our funds coming from private donors. Last year, 450,000 people throughout the US contributed a record $120 million to Doctors Without Borders. And we're, of course, very, very grateful and appreciative for this tremendous support. We understand that it's based on a relation of trust with donors, and that this trust really is our greatest asset. We have to be as accountable as possible, as transparent as possible about our responsibilities, about the needs, what we can do and what we can't do. In addition to the very critical importance of independence, I hope that I've also conveyed to you my second point, the point about the critical importance of innovation. Standards of care are typically low in the field of international assistance, and there's really an ongoing risk, even a temptation, to accept what would be unacceptable in wealthy nations in terms of quality and effectiveness of care. Look, for instance, at AIDS treatment. Was it acceptable not to treat people in poor countries who desperately needed treatment when the life-saving medicines who were saving and extending lives were available to patients in rich countries? Or consider Niger. Was it acceptable last year to sacrifice the smallest children rather than to run the risk of destabilizing the market? We really have to do better, and we can. And this is why innovation is really so important. We need innovative approaches that are adapted to the field conditions, to the conditions that our patients find themselves in, to the level of infrastructure in the countries that we work in. But to have adapted approaches, we need adapted tools, appropriate medical tools, diagnostics, medicines, and vaccines. And the example I gave to you about Plumpy-Nut really illustrates that, the link between the device itself and the approach that it enables adapted to the conditions of the people. But Plumpy-Nut is really an exception rather than the norm. And we have to work towards having research and development guided by the health needs of poor patients and the conditions that they live in. So I'll just leave you tonight with a question that was posed by one of the doctors in the clinic that you just saw in Kenya. She was treating AIDS, particularly AIDS in children. And she very simply asked the question, if these kids were our kids, would we accept it? And of course, I think we all know that the answer is contained in the question itself. But what I really want to stress this evening is that the answer to that question, for me, is not a question of charity, it's not a question of pity, but it's really a question of very basic human solidarity. Thank you.
I thought we'd have a conversation about some of the topics that Nicolas mentioned and try to get into some a little bit more depth. One of the things I think that's interesting is this notion that complacency is preventing folks from responding. And some might suggest that it's not so much complacency, but lack of knowing how to plug in. It seems that there may be a lack of distrust in the governmental action. So there's the One campaign headed by Bono and a lot of the groups that is urging in this country the U.S. government to increase its foreign aid spending. It's a tough proposition in one sense because unless something else gives, it means Americans should pay more taxes to put money into the governmental run programs in which there appears to be little confidence. So how do you get at this issue of complacency, and is it really, do you think, rooted in a lack of concern or a lack of trust in actors that people can invest money in thinking it's going to make a meaningful difference?
It's a good question. It's a complicated one to answer correctly. For me, there are different levels to this. I mean, I think that on the one hand, there is a lack of just basic knowledge about what is happening, and there is a sense, an acceptance of, I think, what we would all consider to be really quite unbearable or intolerable situations. But because they're happening far away, because they're happening outside of the glare of media attention, they just don't rise to a level of concern where actually political forces can and pressures can come into play, and where there can be a response can be developed. I mean, you know, the situation in Katanga that I talked about at the beginning of the talk, it was very, very hard to even raise awareness among the aid community that this was actually taking place, and that we needed the World Food Program to come in to provide food, because there was just nothing happening, and we had to go to quite extraordinary lengths, I mean, including the UN Security Council, and to try to get some response to that. So I think that at least on the level of humanitarian assistance as such, we all know that there are a lot of considerations that come in. I mentioned political interests, I mentioned media attention, and so on. But if you don't have the minimum awareness, you can't generate the response. That's really the fundamental thing. And I'm talking about at least on the humanitarian response as such. Solving the problem, that's a whole other issue. I mean, solving the problem of the deficit in public health systems in Africa, the persistence of war and conflict and so on. I mean, it's in a way that is it's beyond what at least we're focused on, and in a way it's kind of lucky we don't have to answer that question. We can just punt on that one, but it's true. It's one that is very, very complex, and I think we can't avoid governments. I mean, you said there's lack of trust in government-to-government assistance and in the capacity of governments to respond, but in the end, it's really only governments that have the mandate to deal with, or should have the mandate to deal with everyone. And private efforts are important, and our efforts it's a private effort, so I think it's important. But in the end, we choose where we go, what we do. We're accountable to our donors. How accountable are we to the beneficiaries? I'm not very clear about that. I mean, what can people demand our services? We make our own decisions. In the end, it's only governments that should have the public good in mind, both southern governments and wealthier governments in a sense of international public good. And we have to find a way to empower governments, but also to hold them to account for doing that. So I think you can't avoid governments in this. Private initiatives are fantastic, but they cannot solve these problems.
It's an interesting, I guess as an American, I would observe, having talked to folks in Europe about this, it's a senior person in one of the European ministries said, this problem is too important to leave to private industry. It must be governments. And Americans would say often, it's so important, we can't let government get involved because they'll muck it up. And I think the strong support that MSF has in this country, I think, is a reflection of this trust notion that you established. And my question is, as you become the epitome and the focal point of trust and the desire for people, they'd rather not pay more taxes to go into the USAID machinery, but willingly give their money to MSF or even Direct Relief International, do you find yourself being pulled into these policy issues that you might not have wanted to engage in originally, but you find yourself unavoidably pulled into issues beyond the humanitarian and back up the food chain of policy?
No, I agree with you. It's a paradox in many ways, because there's a trust in us as a private operator in many ways, but what we're doing is responding to what is the failure of the political powers. I mean, either failure in the sense that they're attacking their own citizens, or they're allowing this to happen, etc. And by doing that, we're putting our finger on it and hoping that the politicians will take the responsibility. So our action should not be a substitute, for government action, but it should be a trigger for government action. We're trying to responsibilize even by the mere fact of doing what we do. We're putting our finger and shaming, hopefully, governments to actually respond and do something. And so, we get drawn into the policy discussions. We try to avoid getting into the realm of the political, proposing solutions, making policy recommendations, because it's beyond our competence, it's beyond our legitimacy, and it can interfere with the concrete, practical work we do of providing assistance. So we stay away from it. We are pulled in that direction, very often, but I'm aware of this paradox that you referred to, and it's a little bit disturbing to me, but I recognize it, and I think we need to empower. I mean, I don't want to be an advocate. It's bizarre for me to stand here and be an advocate for USAID, but I think we do need international aid. We need the Global Fund. We need these institutions. We need the World Health Organization. We are not the World Health Organization. You know, we need these bodies. We need the to be able but we need them to be much more accountable than they are, and much more serious than they are today about fulfilling their global duties, because they're failing to a very large extent. I think we could all agree on that.
Right. I think also you mentioned this. You mentioned the tsunami, and I think a lot of the international organizations experienced a year of unprecedented giving, where these high-profile disasters with this intense global media coverage brought home in a way that the slow-motion disasters don't, and it spurred a lot of giving around the world. And if you assume the proposition that democratic governments reflect basically the interest and priorities of their constituency, and those interests aren't being reflected in increased foreign assistance, but individuals themselves want to give money to the tsunami or Pakistan, how do you reconcile that? I mean, who substitutes the judgment for the people? I think it's a political question in a sense, but I think it's one that is important because of the enhancing prominence of NGOs, which in one sense were a reflection as governments started to fail. NGOs filled the vacuum. But is that trend reversing yet, or are NGOs likely to continue to expand? And if so, how do they reconcile themselves in this new role as something between a business, private enterprise, responsible to its investors, and really assuming a role that government either is unwilling or unable to do? Do you see that trend changing?
Yeah, I think for us there's a danger in just becoming a service provider that is, just basically a bit cheaper or a bit more effective than government, and therefore working, being the implementing agency of the government that doesn't want to bother to carry out these services themselves and just subcontracts, a non-profit provider. There's a real risk in that, and there's a risk, less in conflict situations for us because governments wouldn't do this anyway. But in AIDS, there's definitely a risk in that, where we're treating patients, we're putting them under treatment, of course we're pushing the envelope, we're trying to do new things in different ways, etc. But there's a risk that governments will say, well, look, great, they're doing it, let's find a way to subsidize that practice rather than get involved and do it ourselves. So we have to create a situation of tension with governments. If there is no tension with the governments, we're actually not doing our job, because we're not reaching the people who are most vulnerable, who are most discriminated against, who are the ones who are left aside by government. We have to have, inherently in our practice, there's a situation of tension with governments. And when we become associated and just the service providers alongside the governments, then we're failing, at least as a humanitarian organization, we're failing to carry out our role, which is one of, again, stimulating, provoking change as much as it is carrying out needed services.
In your examples, I think one of the themes that struck me was something we see at Direct Relief International, and that's kind of the mutually reinforcing effects of poverty and poor health. If you're sick, you tend to get poor, and if you're poor, you tend to get sick, and you can't get out of it. So I think breaking that cycle in a world that globalization does work. It does spur innovation, and people willingly move capital across borders, and people willingly receive capital inside their countries, really driven by a profit incentive. And what's your take on how the combination of an increasingly globalized world market for goods and services and medical talent, which draws African doctors to Europe and the United States, with the lack of incentive for the forces of globalization to kick in and put that power behind some of these issues, keeping people in poverty? Do you see a way to influence these wonderful innovation and drive of globalized forces and bring them to bear to address issues of poverty and poor health?
I don't know
and
how
what
I
is the
can
meaning
answer
of
that.
life after that, if you would?
I don't know how I can answer that. I mean, one thing that you mentioned is something that we experience a lot, and it's a real constraint in our operations, is the forces of globalization affecting, poor, the scarce resources in poor countries, clearly. I mean, the brain drain and people, the lack of human resources in developing countries is a major constraint on the way, we can operate in the way, and it forces us to adapt our approach, definitely. So we see the negative aspect in a way of globalization, because we just, in Malawi, treating AIDS in Malawi, the doctors are just not there.
Right.
You have to find a new way to deliver AIDS treatment to simplify, without the kind of system that we have here in the United States. So it's more a constraint than anything else. Whether we can harness the forces of globalization to alleviate poverty and improve global health, I wish that could happen. We don't play a direct role in that. I don't think, or maybe we do, but I'm not aware of it.
I had no idea what the answer was myself. I was hoping you had the answer to that. The force of global. There's a series of questions about globalization, and one of the things that I know that you must experience is that what you mentioned in Malawi, where there's 100 or so physicians for a country of 11 million people. But I'd ask you to comment on something I think I've observed maybe a trend that's coming to this country soon, that's evolving in developing countries, is the lack of resources is causing a segregation of clinical skills. Here you're a doctor, you're not. Now there's physician's assistants and the paraprofessionals, right, paramedics. And in Africa, with the high talent often leaving, they're training a series of individuals, from midwives to clinical officers. And if you could talk about how MSF is looking at the human resource as you bring your talented staff in, how you try to leave something intact so people can continue with the work after your teams may leave.
Yeah, it's, the main impact that the lack of qualified human resources, or the lack of at least the most skilled human resources, doctors and others, is causing on our programs is the need to, as I mentioned earlier, is the need to adapt and to simplify, because we have to treat it as a constraint. It exists, it's there. Let's hope that the brain drain is reversed. It doesn't seem very likely, and even if it were, you would still have, a lack of doctors and lack of infrastructure anyway. So we have to find new ways. That's why I highlighted this example of this plumpy net thing, because I think it's so illustrative of the kinds of thinking we have to do as well for AIDS in particular. If we think that to detect viral load, you need to have a hospital with a lab and and a test that costs $50 or $100, you won't be able to monitor viral load in so many patients and be able to detect when to switch them to more effective therapy. You need to have a rapid-to-use test for viral load that you can use at the health center level. You need to adapt your medical tools, and we need to find, and actually on this is an example that we're working on actually today with in partnership with with a group in Cambridge in the UK, and we hope to develop this in the next few years. So we have a test that will cost $6 or $8 and be used at the health center, so you can find out if the viral load threshold of a patient to be able to switch therapy. That's a concrete answer to a human resource and an infrastructure problem. So we're thinking more along those lines in how to address this problem, adapting and simplifying to be able to treat people, and then training people on the job. Clearly, we don't have training programs as such, standalones, medical universities or something like that doesn't exist. But we train a lot of people in our daily practice, and hope that they can carry on and learn a lot of skills and be able to carry on when we're no longer there.
And actually, I have photographs when we were traveling in northern Zambia of the MSF diagnostic checklist that a paraprofessional can look at a person and look at their conditions and go through basically a checklist and dispense medication. There's no pharmacist for miles, there's no doctor for miles, but I think that is the type of innovation that you've been leading on. I think it's really important as you project what's happening in this country where the market forces drive where the money is, to turn to a bit to the issue of drugs. In the United States, it's 16% of an $11 trillion economy, health services, and the market forces work. So a lot of the drugs in development relate to lifestyle, obesity, an aging population, erectile dysfunction, if you watch TV. Who's laughing out there, actually? Is that all of which are important and all of which apparently work, and that the people with the money experience those conditions. The market projections are driving the long pipeline of research and development. But those are not the things that are killing poor people. So how do you create those incentives? I think this is something I know that you've been involved with and really leading on, so it's a softball question. How do you create pools of money to give folks the incentive to develop drugs and other material to serve conditions suffered by poor people and not just those who have money?
Well, yeah, I mean, it's a very, you're making a very important point. There are, less than 1% of new pharmaceutical compounds that have been brought to the market in the past 25 years have been for diseases that affect the poorest, tropical diseases in particular. So we need a change of model. Now, the main, there has been some movement in this area. I think the main movement has been the creation of public-private partnerships that are disease-specific. So you have one for malaria, you have one for tuberculosis, you have one for diagnostic tests. Actually, and they try to bring in money from different sources and the expertise of the pharmaceutical companies, and have a new kind of leaner system to be able to develop drugs on a non-profit basis. And there are some things in the pipeline. There's some development, so it's promising. There's a bit more activity in this area. There's some weaknesses, though. One, the money is coming from a very few sources. They're actually big philanthropic foundations, the Gates Foundation being one of them. So it's great, but you're relying on the goodwill of one or two individuals. So we need to make these, and of course, you wouldn't rely on, to get a new drug for cancer, you wouldn't rely on one public-private partnership for cancer. You would have many, many different groups working side by side and so on. And that you don't have. I mean, if you have the one malaria group that have different compounds, but it's one group. So but it's better than what we had a few years ago. So I think we can start to build on that. What needs to happen is, one, you need to have a real needs-based research agenda. There has to be a list of what are the top priorities for research. So actually Gates did that on his own. They launched a kind of contest on that. What are the great challenges and so on. We're pushing for the World Health Organization to take that role internationally. And there's actually a resolution that's going to be at the World Health Assembly in a few months that is precisely on that, a needs-based research and development agenda. And then you need to have, but the pharmaceutical companies, they admit that they're not going to do anything about this. It's not their stakeholders don't ask them to work on this. It's Wall Street doesn't ask them to work on this, and so they won't do it. They might allow some of their facilities to be used by non-profits if the non-for-profits pay for their facilities to be used for the drug development. That is happening in the public-private partnership model. That happens. But they're not going to get involved. So again, I'm sorry to come back to governments, but you need to have some incentive and some teeth that push governments to get involved in some way to back research and development for drugs that and for treatments that affect poor patients.
Right. Thank you. I'd like to ask you, just because again, it's an ethical question. How do you reconcile, as a private organization, this is something our organization addresses and many others do, reconcile the desire to help with the knowledge that you can help without objectifying people who are poor by making, putting a distance between, they're people, and they're people living in difficult circumstances, and we've all seen people who cross that ethical bound of just a guilt-driven, emotion-laden appeal to get in your wallet. But with the Nobel Peace Prize and really a singular position in the world, your organization must deal with this ethical dilemma of the urgency of the need, and knowing that the reason people do these emotion-laden appeals is because they do work. But in the long run, they tend to put a distance. So how does MSF deal with those internal ethical issues of how to present an issue affecting people without making the people objects that are pitiful as an excuse to get money to help them? If that makes any sense at all.
No, it makes a lot of sense. It makes a lot of sense, and it's something. You're right. There's always a temptation of doing that because you need, the emotional aspect does trigger, not just giving but action and so on. And we saw it. I mean, that's the Niger example for me is characteristic of that. Actually, the BBC images that were shot in our feeding center. That was basically the only place that where malnutrition was being treated in Niger at the time. They were the kinds of images that we actually don't. I mean, we actually don't want to see this, anymore. It's the starving African child, fly in the eye kind of pictures that. I mean, both it's really showing that the crisis is almost at its peak and or past its peak, and it's it's very late. And it does trigger this kind of, either pity or guilt or some kind of charitable, that is actually not productive if you want to. I mean, it's productive in the sense that it triggers something, but it's not productive in the long term in really dealing with these problems that have to be dealt with in a much more systematic way. So, but the reality that if those pictures hadn't been shown, I think it would have been even worse in Niger last year. There would have been hardly any reaction. And it's not just individuals, it's aid agencies themselves, it's governments, the UN system. I mean, this moved everyone to act. So we try to limit it in our own materials. I mean, we try to not have the kinds of images and objectifying poverty and despair and so on. But the stuff that we do, I mean, we do see people who are in very bad state, and at a certain point you have to show it as well. You have to show what the reality is. I mean, I showed you some images today that are pretty shocking, where people are not at their best. It's a little bit undignified to show patients with who've been shot or so on. But that's also what we deal with. So it's a difficult one. Sorry, I'm rambling, but it's a difficult issue to deal with.
Thank you.
Thank you.